Hi, for my 5-minute video, I'm going to talk about the precocious puberty. What is precocious puberty? Puberty occurring at an unusual early age may have adverse effects on social behavior and psychological development. Early onset puberty, especially in girls, is becoming a lot more common and not necessarily abnormal. However, it can be distressing for parents and harmful for children to mature um, physically when they're still immature mentally. Generally speaking, less than 8 years of age in girls and less than 9 years of age in boys. What put people at risk for precocious puberty often can't be found. Rarely, certain conditions such as infections, hormone disorders, tumors, brain abnormalities, or injury may cause precocious puberties. There are two causes that are split into central and peripheral. Central causes is gonadotropin dependent, caused by a premature activation of the HPG axis. Peripheral causes are gonadotropin independent and stems from increased secretions of the sex hormones. And other causes can be from adrenals and HCG production by the germ cell tumor or exogenous sex hormone. Primary hypothyroidism and McCune-Albright syndrome are also causes of the peripheral. Three key questions to ask is going to be the thorough history medical exam, including their height, weight, height velocity, whether it follows a normal pattern of the endocrine changes or not, onset of their secondary sexual characteristic in girls, onset of their first menstrual cycle, recent growth, family history, detailed medication history, assess the risk factors such as child or sexual abuse. Of course, we'll use using the Tanner staging. First sign of for females would be breast development, and first sign for males would be testicular growth. Diagnosis and treatment, height measurements and growth charts are really important. Non-dominant hand and wrist X-ray, serum estrogen and testosterone levels, serum follicle stimulating hormones, luteinizing hormones, usually high in central cause and low in peripheral cause. Prolactin, thyroid stimulating hormones, or free T4, screening for chronic disease such as getting CBC, ESR, and liver function tests, pelvic ultrasound in all girls. GDPP is a gonadotropin dependent, so we'll get a brain MRI, evaluation of all other pituitary hormones, overnight sampling of the GnRH. GIPP is a gonadotropin independent, so serum 17OH, which is raised in the CAH, CT scan of adrenal glands. Treatments will be GnRH agonist preparations, 3 months of preparation of the leuprolide, starting at the dose of 11.25. And if puberty is not adequately suppressed, can decrease the interval between the doses or titrate up the dose. Children younger under the age of 2 or children with hermatomas often use leuprolide depot given IM every 28 days with a starting dose of 7.5 milligram. And after suppression is achieved, can switch to every 3 months. Monitor the response of the GnRH agonist by assessing the pubertal development and height velocity every 3 to 6 months, and bone age initially every 6 to 12 months. Generally continue the treatment until age of 11, and female until in age of 12 in males, and the decision to discontinue the therapy is individualized. Thank you guys for watching, and I hope you learned something.